Family Medicine Step to CK, UWorld, and NBME Style Review. So today we're going to be looking at family medicine and going through some high-yield topics. And the best way to study family medicine is to actually first look at the kind of questions that may be considered as a family medicine kind of a question. So we first need to look at those questions. When we look at those questions, and then we have to go towards their explanation and then go towards all the material that we should know. So we would first start by going through a question that can be rightfully said that it belongs to the family medicine category. And then we would move on and we would look at the explanation that is needed to solve that question. So that is how I think family medicine should be covered, as there is no specific book for it or no specific resource to cover family medicine as in itself. Internal medicine you can cover from other resources as well, but family medicine in itself is important, and the best way to study it is to differentiate it from other disciplines. Right, so let's go. The 67-year-old woman presents with a 1-month history of worsening constipation, diffuse crampy abdominal pain. She reports that her usual bowel pattern alternates between 2 bowel movements per day and 1 per week. Her most recent bowel movement occurred 4 days ago, and the stool was hard. She stopped taking laxatives because they caused diarrhea and fecal incontinence. A colonoscopy performed 3 years ago was normal. She has major depressive disorder and anxiety, treated with sertraline and lorazepam. She is afebrile and appears comfortable. The abdomen is soft and non-tender with decreased bowel movements. Rectal examination reveals no masses or stool, and the fecal occult blood test is negative. Which of the following is the most appropriate next step in management? So this question is a classic example of a question that is testing you on family medicine basics. Mostly patients that present in a family medicine setting or a primary clinic would not present with acute conditions. They would present with chronic conditions. So keep a lookout for that. Because if in a question, the patient is presenting to a primary clinic, it means that that condition is most probably a chronic condition, not an acute condition. And if you know this part that it is a chronic condition, then the management of the condition would also be something that is less invasive and something that has less side effects. On the contrary, if a patient is presenting with an acute condition, then the treatment of that condition would also be aggressive and might be more invasive or might have more harmful effects to the patient. So that is how you can get towards the right answer as well. So you can read the options here. And the right answer for this question is trial of fiber supplementation. Now, how is it right? So first of all, you need to understand that I'll show you the question once more. You can read it. And concentrate on the parts that I have highlighted, such as this and this. So to solve this kind of a question, you need to first understand the clues that are given. So she was an elderly woman and had a chronic pattern, years of constipation. She had no alarm symptoms, no hematochezia, melena, anemia, unintentional weight loss. So basically, melena is upper GI bleeding, and hematochezia is lower GI bleeding. So melena usually can present with dark stools, and lower GI bleeding or hematochezia can present with bright red bleeding or blood droplets or blood stained fecal content. So you need to remember that this would present as a dark stool, dark maroon stool, or black. So that is how it can present. So she had no hematochezia, no melena, no anemia, no unintentional weight loss. She also has no family history of colon cancer or abrupt change in stool caliber. So it was not like that she was having hard stools a few days ago, and now she's having diarrhea. That's not how it happened. There was consistent stool caliber. She was having constipation. And also, this is not an acute condition. This is a chronic condition. Also, the clue is that the recent colonoscopy was normal. So if the recent colonoscopy is normal, then by looking at this point, rule out, you can rule out, forget my drawing, you can rule out cancer, right? You can rule out colorectal cancer. So looking at all these clues, we are pointed towards functional constipation. You can see that we would never repeat colonoscopy, and we would never do trial of acidophilus because this is an antibacterial. We would never do that. This is not an infectious etiology. We would also not discontinue surgery because antidepressant have no effect on GI movement. They cannot cause constipation or diarrhea. That is not a side effect that sertraline is known for. It can cause weight gain, it can cause sexual dysfunction, but nothing else. Nothing else related to the bowel movement. Lorazepam also does not cause constipation. Opioids, however, do, but she is not taking any opioid. CT scan will not be done because, again, there is no cancer. Colonoscopy was normal. And abdominal X-ray will show us nothing. This is usually done in obstipation. Which is which is acute worsening of chronic constipation. So let's move on. The secondary causes of constipation. So this is where our family medicine review actually starts. So what are the secondary causes of constipation? Basically, they are divided into these different categories, one of which is medications that include opiates, anticholinergics, calcium channel blockers. Antihistamine is also included in anticholinergics. You must remember that first generation antihistamines have some anticholinergic properties. Iron, aluminum antacids, benzodiazepines, and SSRIs. So, benzodiazepines and SSRIs are mentioned, but you must understand that in a scenario in which multiple etiologies are given and the question is trying to push you towards a single etiology, then you must go towards the most common to the least common. So these are the least common effects. This is not the first case scenario or the first line etiology that comes to your mind. This is not the most common reason of constipation. And this is not also the most common side effect of SSRIs and benzodiazepines. So you will not go as far as to consider them. But if you are facing a question that forces you to choose a benzodiazepine and SSRI, in that scenario, it is important that you know that these medications, in a very rare instance, can cause constipation. You must know that. But after ruling out all the other options, you can come to this conclusion. This will not be your first choice. That is what you must keep in mind. These will be your first choice. All of these. Okay. This is classical. Also, these are classical. But these are the least common. So these won't be your first choice. But they can come in a difficult question. They can push you towards them. You must always follow the direction of the question. Metabolic endocrine hypothyroidism can cause constipation, hypercalcemia, can do that. Hypokalemia, diabetes mellitus, neurologic, Parkinson's disease, multiple sclerosis, spinal cord injury, structure, chronic strictures, neoplasm, ectosil, functional, which is what we have here is idiopathic. Because all of these were essentially ruled out. It was not matching to any of the other categories. So it was idiopathic. That is why we called it functional constipation. Functional, we would always call something which is either idiopathic or occurring due to a physiological mechanism. Poor dietary fiber, dehydration, inactivity. Dehydration is also a big part. You must know this is also important, that dehydration can cause constipation. So the algorithm we would follow is, first of all, we would initially evaluate the patient. We would go towards the history and exam. We would review all the medications to rule out the medication category, to rule this out. So we look at all the medications and then we will look for alarm features. Alarm features such as blood in stool, all of these you must remember. These are important. Such as blood in stool, weight loss, anemia, new onset constipation after the age of 50, family history of colon cancer, or palpable mass or abdominal rectal exam. So all of these are alarm symptoms that you should remember. These are important. If there are no alarm features, then you proceed with the empiric management. If there are alarm features present, you go for colonoscopy or the CT of abdominal pelvis. Colonoscopy is our first choice, and then we go towards the CT to basically stage the cancer. All right. So empiric management. So as she had no alarm features, so we go with this route. We go towards the empiric management. What the empiric management is basically we increase the dietary fiber and water intake. Plus, we tell them to regularly exercise. All of these come into empiric management. All three of these. You cannot do one and not do the other. You all three of these, dietary fiber, water intake, exercise, all three of these come under one umbrella. All right. So the fiber goal of patients is 20 to 30 grams per day. And the first fiber that we basically prescribe is psyllium. This is also a CMS form answer. This is in your CMS forms. And methyl cellulose can also be used in its place. So all of the material written here, guys, is very important that you must keep this in mind and understand it. So we first prescribe dietary fiber. Which fiber do we prescribe? We prescribe psyllium or methyl cellulose. Then we tell them to increase their fluids and daily activity. And we must tell them that the improvement will take around 2 to 3 weeks. Okay. If there is no improvement, we go towards the osmotic laxatives. You must remember that osmotic are given first. Then we give stimulants. So we go towards the osmotic laxatives. The osmotic laxative that is most commonly used is polyethylene glycol. This is most commonly used and this is also asked in your NBMEs. Lactulose or magnesium hydroxide can be used, right? So aluminum we had studied previously can cause constipation. Magnesium can cause diarrhea. So you must remember that polyethylene glycol PEG can cure constipation, can treat constipation because it causes diarrhea. So you must know both of them. Mechanism is that it draws water into the bowel lumen. It has more osmolality. So if it has more osmolality, then water is attracted by more osmolality. The water goes from higher water concentration to lower water concentration. Higher osmolality is same as having lower water concentration. So water molecules will move into the higher osmotic space, which is the space in which polyethylene glycol or lactulose or magnesium hydroxide will be present. And then the constipation would be treated. If there is persistent symptoms, then we go for stimulant laxatives. What they do is they stimulate the chronic motility, and bisocodil and senna are the most common ones that you must remember for your exam. They are used intermittently because they can lead to dependence. So what happens is if the patient regularly takes these stimulant laxatives, the patient can induce dependence on these laxatives. So what we do is we prescribe them intermittently. There is a break period of 1 to 2 weeks during which other laxatives are given. And that break period is important so that the receptors in the colonic mucosa are not down regulated or are not oversensitized by them. They are important. Uh, this intermittent schedule is important to prevent dependence. So you must know that these can cause dependence. However, other laxatives will not cause dependence. If the symptoms are still present, then we would go for prescription options, such as secretagogues, which are lobiprostone, which is a chloride channel activator, linaclotide, which is a guanylyl cyclase C agonist. They increase the bowel motility. They increase the secretion potential. They increase basically the secretagogues, so they increase secretions. And we have to also evaluate for defecatory disorder, which is basically, we can do that with anorectal manometry or balloon expulsion test. This can include Hirschsprung's disease, right? Which can be evaluated by anorectal manometry, balloon expulsion test. Basically, this is evaluated to see if the defecation process is intact. This is the empiric management. Most important, the differential diagnosis. So when you will be reading these questions, obviously there will be multiple diagnoses coming to your mind. And how you differentiate between those diagnoses is what will make your case. So the differential diagnosis are as follows. Number one, functional constipation will have chronic history, normal exam, no alarm features. Diagnostic workup would be clinical. It needs no other test. There is stepwise management. We give fibers such as psyllium or methylcellulose, and then we give PEG, and then we give stimulants. Stimulants, you can see bisacodil or senna. Then there is medication induced. We use it is due to the use of opioids, anticholinergics or SSRIs, and diagnostic workup is through medication history. We discontinue or substitute the offending drug. Hypothyroidism. You would also have other symptoms of hypothyroidism such as fatigue, cold intolerance, bradycardia, and diagnostic workup is through TSH and free T4. Levothyroxine replacement is the treatment. Colorectal cancer. It is pathognomonic. It is the most important clue for colorectal cancer would be new constipation in elderly. So new onset, weight loss, blood and stool, anemia, and it would be detected by colonoscopy. Surgical resection is the treatment, and we would also give adjuvant therapy such as chemotherapy or radiotherapy depending on the stage of the disease. Irritable bowel syndrome. It would have an alternating constipation and diarrhea, pain relieved by defecation. Right. So it follows the wrong four criteria. It's not important for you to memorize for step two, but you must just know the name, wrong four criteria. Otherwise, it is a clinical diagnosis. It has alternating constipation and diarrhea. So you must remember that. And pain relieved by defecation is also classical for it. Management is through dietary modification. We give fiber or osmotic laxatives, and there is a food map diet, particular food map diet, which the patient is advised to follow. Fecal impaction. It happens in elderly and immobilized patients. It can present as rectal fullness, which is palpable on physical exam. And it can also present as incorporesis or overflow diarrhea. You must know that the other name for this is incorporesis. Starts with an ENCO, incorporesis, PARESIS. And it is diagnosed by rectal examination. You can visualize the stool in the rectal vault. Treatment is manual disinfection and enemas. Parkinson disease-related dysmotility. It will have clues such as bradykinesia, rigidity, tremor. Classic Parkinson picture would be present. It is a clinical diagnosis. And dopaminergic therapy to treat Parkinson can be beneficial in this. Also, stool softeners can be used. Pelvic floor dysfunction. Clues such as prolonged straining, incomplete evacuation would be given. Anorectal manometry will be done to diagnosis. And biofeedback therapy is basically done. What biofeedback is that basically various processes are, various stimulations are given to the pelvic floor, and then the pelvic floor response is checked. So if there are electric stimulations given, and then if the pelvic floor functions, that is what is done. Even medical management can be done, Kegel exercises will be done, and then we can see and observe that whether the condition improves or not. So all of that is collectively known as biofeedback therapy. We would study about this more later on, but this table is important for you. It basically summarizes the differential diagnosis of constipation. High yield. All right, so a little bit about diagnostic testing if needed. CBC can be done to check for anemia if alarm signs are present. ESH and calcium and glucose are important because we need to rule out secondary causes, as all of them can cause constipation. Colonoscopy is important if there is new onset and the patient is greater than 50. So in our question, the patient was older than 50 and colonoscopy was already done. Colonoscopy will be done in all patients. In all patients greater or equal to 50 years. And manometry will be done if it is refractory or there is any outlet dysfunction that is suspected. And management pearls for the elderly, you have to encourage regular toileting routine at the same time, especially post-meal, and avoid chronic stimulant laxative use because it can cause dependency and colonic inertia. So it can worsen the problem. Encourage high fiber foods such as fruits, vegetables, whole grain, bran. Ensure adequate hydration, especially if the patient is on diuretics. So adequate hydration would be done. Address psychotropic medications. Both sertraline and lorazepam can contribute to constipation. So guys, all of this is very important because these points themselves can be asked. separately in different questions. Red flag features. Sorry about that. Red flag features that you must not miss in the elderly. If any of the following are present, you do urgent colonoscopy and imaging. We have also discussed this, but briefly I've mentioned because new onset constipation greater than 50 years, blood in stool or positive FOBT, which is fecal occult blood testing, unexplained weight loss, iron deficiency anemia, family history of colorectal cancer or IBD, and palpable abdominal or rectal mass. So you must remember that alarm signs. All of these are very important, very, very important. Uh, that is why I'm emphasizing on it again and again. The next best is to have logic. The clinical settings, if the patient presents with constipation and no red flags, you give a trial of fiber supplementation. If the patient presents with chronic constipation and red flags, you go for colonoscopy. If the patient presents with constipation and medicine use, you go discontinue the offending agent. And if the patient presents with severe abdominal pain, no stool flatus, distension, this contributes towards, these both contribute towards obstipation that we discussed. In that case, you will do abdominal X-ray or CT to rule out obstruction. So if you remember, I discussed obstipation. We will do abdominal X-ray in that. And if there is normal colonoscopy but persisting symptoms, you evaluate for defecatory disorder through anorectal manometry. Elderly plus chronic pattern, normal colonoscopy, functional constipation, do not jump to imaging. And SSRS can cause mild constipation but not severe enough to stop the drug. If clinically effective, lorazepam can worsen constipation but should be reduced only if clearly caused. Only if the question is pushing towards it. Fiber first, not films. Always go for the initial management of giving fiber. And this is basically a summary point for the pharmacologic management, such as fluids. These are first line for functional constipation. PEG increases stool water content. Stimulant laxatives stimulate peristalsis. Secretagogues are for refractory cases only, and colonoscopy for alarm features. So that is it for this topic. So question number 2. A 4-year-old girl is brought in with a 1-day history of sore throat and fever up to 101.8 degrees Fahrenheit. Several classmates have had similar symptoms. She appears uncomfortable but alert. Examination shows tonsillar erythema with exudates and otherwise normal findings. A rapid antigen detection test for group A streptococcus is negative, but a throat culture later grows streptococcus pyogenes. Which of the following test characteristics best explains the discordant results? So this is a kind of a family medicine question that is also incorporating pathology and a sort of a biochemistry, uh, excuse me, sort of a biostats concept also. So the answer is low sensitivity. And how is this the answer we're going to discuss right now? So what the result means, what they're saying is basically the girl has had a history of sore throat and fever, and the rapid strep test is negative, but the throat culture is positive, right? So what they're saying is why is the what characteristic explains the result. So basically, what they're saying is that low sensitivity, because of low sensitivity, the rapid strep test gave a negative result, and the throat culture gave a positive result because the throat culture is more sensitive. So let's discuss this a bit. Right, so what the results mean is that the rapid antigen detection test missed a true positive case. So the result was false negative. And false negative always occurs when a test lacks sensitivity, meaning it fails to identify some patients who actually have the disease. The sensitivity's definition is sensitivity is true positive that divided by the total of true positive and false negative. So a low sensitivity test means that there are many false negatives and there are less true positives. So the disease will be missed. That is what basically this means. As it happened, that the test missed true positive and gave a false negative result. Right. So characteristics of a rapid step test. Positive rapid step test is a rapid antigen detection test, or rapid step test is both the same thing. So don't get confused. So a positive test is confirmatory, but a negative test cannot exclude the infection because it is a low sensitivity test. Now, if this test had a higher specificity, it would mean that a positive result almost always means a real infection. But if the test had um, low sensitivity, it means that a negative test is not fully negative. Do you understand that? A positive specific test always means a real infection, but a low sensitivity test means that the negative cannot be missed. Let me explain this in a better way. So, if the test is more specific, right, it can rule in a disease. So this is represented by the mnemonic spin, right? Specificity is the absence of disease when the disease is not present, or the presence of or the positivity. Let me explain this another way. So let's study it this way. So what happens is that if the test is very specific, it can rule in a disease, right? According to the mnemonic spin. And the test is very sensitive, it can rule out a disease, which is by the mnemonic snout. So that's why screening tests have high sensitivity, right? They have high sensitivity is because they can capture the disease properly. Now, this test, the rapid antigen detection test, should have high sensitivity, right? It should have high sensitivity so that it detects all of the cases, right? But it is giving us a false negative result, which means this is not a good screening test, which means it has low sensitivity. It has low sensitivity, right? If it would have given us a false positive test, if it would have given us a false positive test, then it would have low specificity. So this is the biostatistics concept that is being applied here. We don't need to make it more complicated. This is what we need to know for this concept right here. That screening tests are supposed to have high sensitivity. They're not supposed to have false negative tests. But this test in the question has low sensitivity because it is having a false negative result. On the contrary, highly specific tests, which are confirmatory tests, should be highly specific. Any test that is confirmatory, for example, um, a biopsy is confirmatory, so it should be very specific. If it is not specific, it would give us a false positive test. If it is false positive, then we would start the treatment on the patient, and later on we would get to know that it was a false positive, and the treatment would be causing harm to the patient more than the benefit. That is why we need confirmatory tests to be very specific, so that before starting the treatment, we would know that the patient is rightfully infected. Right? So a low sensitivity test has many false negatives and the disease is missed. But something more important that is need to be studied is the general picture. So why it matters in children? The children have a higher risk of rheumatic fever and suppurative complications from untreated strep pyogenes infection. Therefore, if a child rapid antigen detection test is negative, a confirmatory throat culture is required. In adults, the incidence of rheumatic fever is very low. So a negative rapid antigen detection test can be accepted without cultural backup. This is the primary reason why we need to follow it up. You need to remember this. This is the primary reason. The characteristics are explained. Sensitivity is probability that a test detects disease when it's present. And specificity is the probability that the test is negative when disease is absent. The clinical use is snout to rule out a disease and spin to rule in a disease for specificity. Example, a negative identity doesn't rule out strep because it is low sensitive. Would have had a higher sensitivity, it would positively rule out the disease, but it doesn't rule out because it has low sensitivity. And a positive identity confirms the strep because it has high specificity. So if it is positive, it will confirm it. The positive predictive value is the probability of the disease is present when the test is positive. It depends on prevalence, and PPV increases with more strep in the population, which means more prevalence. The negative predictive value, probability of the disease is absent when the test is negative, depends on the prevalence also, and the if it is low if the disease is common. It would be high if the disease is rare. All right, you need to remember that. Likelihood ratio is the combination of sensitivity and specificity, and it is a quantification value. So it is not really tested much. It is used in Bayesian reasoning. Not important for our discussion today, but this is used in uh, pre-test probability and the post-test probability. All right. So common causes of false result. So false negative when the test has lower sensitivity, and false positive when the test has lower specificity. So you need to remember, if you identify any one of those, you need to link it up to its partner. So low sensitivity or low specificity, you need to identify that. Anyone would be given in the question. So if it is false negative, the cause would be poor sample, or if it is an early infection or it has low bacterial load, the test cannot detect it, but the culture would be positive. More sensitive test would be positive. If it is a false positive test, it means that some cross reactivity or colonization or lab error has occurred. The culture would be negative. So it is culture would be negative, but the test would be positive because it has low specificity. Diagnostic algorithm for suspected strep pharyngitis is to assess for symptoms using the Centaur or the McIsaac criteria. This is the Centaur criteria. This is the Centaur criteria, which you must know. So fever is 1 point. Presence of tonsillar exudates is 1 point. Tender anterior cervical lymphadenopathy is 1 point. The absence of cough, not cough, absence of cough is 1 point. And if the age is from 3 to 14, you add 1 point. If it is greater than 45, you subtract 1 point. So if the score is greater or equal to 4, then it is a bacterial infection. And if it is lower towards 0, it is a viral infection. So there is no need for testing or antibiotics. So you must know if it is 4, the higher the number, it is pointing towards antibiotics, and the lower the number, it is pointing towards a viral infection. So these are the testing recommendations. If the score is on 2 to 3, then you must do the rapid antigen test. But they rarely give you a situation in which you have to choose between RAD and other options, other or similar options. They would give you a very easy scenario. So the interpretation is, if the positive rapid antigen test is positive, then you treat with penicillin, amoxicillin. If the score is between 2 to 3 and you are doing the rapid antigen detection test, if it is positive, you treat with amoxicillin or penicillin. If it is negative in children, you go for throat culture because we need to be sure. We cannot leave it. The children will face massive side effects if this goes untreated, and it is rheumatic fever. So we need to be sure that there is no infection. But if it is negative in adults, then you don't need any culture. You should just continue on. There's no need. Treatment overview is to prevent acute rheumatic fever, peritonsillar abscess, and glomerulonephritis. All of this can occur due to rheumatic fever. So, diagnosis is group A pharyngitis, you give penicillin or amoxicillin, and the alternatives are important. If they have a penicillin allergy, you give macrolides. You won't give cephalexin, but can give cephalexin if penicillin or amoxicillin is not available. So you can give cephalexin, but if they're allergic, you will not give cephalexin. You will go to macrolides directly. And to prevent recurrence, you can give benzathine penicillin G. Differential diagnosis for exudative pharyngitis. So if the condition is group A strep, clues would be fever, exudates, tender nodes. There would be no cough. So no cough is bacterial. You would go for the rapid antigen detection test and the culture, and you would manage penicillin and amoxicillin. EBV, if the patient has EBV, it would be fatigue and posterior cervical lymphadenopathy, which is important. Pathognomonic for it, and splenomegaly is also important. This would be present. You will do monospot test or heterophile antibody test as a diagnostic test. The management will be supportive. You would avoid ampicillin because ampicillin gives a rash in a mononucleosis patient. So if you given a teenager ampicillin thinking that it is a bacterial infection instead of EBV, and he presents with a rash the other day, it is not ampicillin allergy, it is just a mononucleosis infection. An allergic reaction to ampicillin would have a full body rash and other symptoms as well. So you need to keep that difference in mind. Adenovirus would have the clues of conjunctivitis and pharyngitis. It's a clinical diagnosis and treatment is supportive. And Neisseria agroria pharyngitis is due to oral sexual exposure throat culture on Thermartin culture. Treatment is ceftriaxone. Diphtheria, gray pseudomembrane would be present and child would be unvaccinated. So the diagnostic test would be culture plus toxin assay and antitoxin plus penicillin, erythromycin would be present, would be the therapy for management. But you would do the toxin assay for confirmation of diphtheria. High yield so rapid specific but not perfectly sensitive, RADT, rapid antigen detection test. False negative means that it has lower sensitivity and high specificity. It is not a good screening test. So in children, you must confirm a negative test with culture. In adults, you need no confirmation. Untreated group A strep infection can lead to rheumatic fever, glomerulonephritis, or peritonsillar abscess. Carrier state, patient asymptomatic but throat culture positive. There is no treatment required. You must remember this, right? Because the patient is asymptomatic, there is no treatment required. And if there are recurrent infections, you must consider tonsillectomy. If there are more than 7 infections per year or greater than 5 for 2 consecutive years. So this is it for this section.